So Bruce is a professor of epidemiology in San Francisco, although he's based in New York. But for many years, he was the director of the New York State AIDS Institute, which oversaw AIDS programming for all of the state. Barb was on a couple of the state committees, and in fact, she chaired one, I think, for a while. And so I got to know Bruce very well. They became very good friends. And then, I met him along the way. And then actually in summer of 2013, I led a trip on behalf of the university to China, and Bruce joined in on that trip. So we became travel buddies as well, and had a great time there. One reason why I approached Bruce for this, his field is not, is not the COVID. He's not an active researcher in that. I mean, he's an internationally known expert in the field of AIDS, travels all over the world. But over the course of the last year or so, he sent out to a long list that I was on terrific sort of updates with sort of the latest things, lots of links to different things. That was really invaluable. So when I was thinking who might we bring in, he was the one I thought of. It took a little convincing. However, he was gracious enough to agree to join in. So actually, we're right about at the 11:30 hour. So why don't I just turn this over to you, Bruce, at this point? I think you can share screen if you want.
Yeah, I will. I will. Just a sec. And I assume you can hear me okay?
Sure.
Mm-hmm.
Okay, great. And I saw it just pop up on the screen that that I think Adrian joined, who was on our trip as well. Right. Yeah, and Beverly. So great. Nice to know that you're here. So great. It's a pleasure to be with you all this morning. I'm actually visiting some friends for the first time that I haven't seen in about 18 months. So I'm in Dutchess County for the weekend, and they've set me up very nicely for this. So just to say, John mentioned I used to work at the State Health Department AIDS Institute. I was the medical director, not the director. So just to, I don't want to expand my role. And there I really had the wonderful opportunity to get to know Barb. And just a background is that one of my colleagues who oversaw contracts and primary care programs said to me at some point when we were bringing clinicians together, "Have you ever met Barb Mahaffey?" And I said no, and we met, and I invited her to join our quality of care advisory committee. And Barb, being Barb, was always very forthright and spoke often sometimes disagreeing with things. It was a really honest and wonderful colleague. And when the opportunity arose, I invited her to be the chair of the committee. But along the way, we also discovered that we had another thing in common, which is that I went to Haverford College, and Barb grew up in a home that I could see outside of my freshman window because her dad and mom, her dad was the chair of the economics department there. And so we had that in common as well. And then I had, as John said, the pleasure of joining him as he led this wonderful group in China. It's hard to believe it was already 8 years ago. It was a wonderful trip. So anyway, I'm glad I could do this today. And I will now share my screen. Yeah, there it is. Okay. You should see it. Can you see it now?
Yep.
Okay, good. I just want to adjust my view so I don't. Yeah. Okay, great. And so I wanted to start off with disclaimers, disclosures and disclaimers. I think, as John kindly pointed out, and he did have to coax me a bit, but because my background is not in COVID. I'm an infectious disease specialist, but I just couldn't help but keep up as best I could, and attended some conferences and kept up with the literature for a while. And so it was an opportunity to stay informed, although, as I said, I'm not a COVID expert. Any opinions, especially toward the end of the talk, are my personal view and take on things. And then finally, the scientific knowledge that I'm going to present is as of now, and it will certainly evolve. And I think, as we know, as I'll show you, there's no shortage of information on the web about COVID. of highly variable quality, even from what we may consider to be reputable news sources. They convey certain messages, and so we get a smattering of different things that our news folks think we need to see. What I'm going to try to do in the next 20 to 30 minutes or so is talk a little bit about epidemiology, a couple little slides on the virus. And I realize that you may be familiar with a lot of this since everything is so available. So you'll forgive me if I'm going over things that you know already. A couple little slides on my summary of where we are with the clinical world, and then turn on to immunology and vaccines. And then lastly, transmission, which is clearly the hottest topic these days, given the recent CDC recommendations. Just to underscore that COVID was a pandemic is really an urgent health crisis, and it requires a multidisciplinary approach to generate solutions. And even just on the scientific side, we need the collaboration of virologists, immunologists, infectious disease clinicians, pediatricians, people who work in drug discovery. So we really need a diverse group in the scientific side. But of course, we also need the input of public health people and social scientists who can help us understand a lot of the issues surrounding the dynamics of transmission, distribution of vaccine, hesitancy to be tested, and so forth, and to say, nothing of communication and public health messaging. And it really requires a collaborative, multidisciplinary approach. So here's a map of where we are today, and looking at the rolling 7-day average of cases per million people across the world. And the shading of the colors relates to the density of cases per million people today. And you can see that, the darker colors are concentrated now in South America, and of course, India, places in Asia, and this really dark spot here, which I'll get to in the next slide, because it kind of caught me off guard. And that's actually Uruguay, which has a lot of cases. You don't hear about it as much in the news. And when I looked at the list of countries, there are Bahrain and the Seychelles also have a really high dense caseload right now as well. But this is where things stand right now. Of course, it hasn't always been like that. And as you can see, we're seeing spikes in different countries over time. And where we are right now is these rising curves here in Brazil, little dip in India, although I think that's going to stay high for a while. And so they're getting a lot of attention, particularly India. And then we see dips in Canada, in European countries, the US and the UK, which I point out here, in just the early part of this year, the high numbers and spikes were in the UK and the US. But when you look today, we see this dramatic decline just 5 months later. And of course, this is the impact of vaccination, and underscores the urgency to get vaccines distributed globally as quickly as we can. As I've mentioned, as you know, that the media is really focused on the disastrous situation in India, where we see people being infected like wildfire, as they say. It's a little curious to me that we're seeing this focused on in a way that we don't see with other countries, particularly Brazil, which has been seeing this kind of a problem for a while. There's been some media attention, but not in quite the same way. But India is really quite dramatic, and we know that there have been, from listening to the news, the shortages of beds and oxygen, and desperation in getting oxygen to people who are sick at home. and need it. And so people are dying for lack of access to oxygen. There are a number of variants circulating in India. I won't go into the details of the strains, but they're also predominant in Australia. And as I'll also mention again later, the good news is that they are controllable by the vaccines that are currently available. India only has 5.5% of people vaccinated. And as one might expect, they're no longer exporting vaccines because they need them at home so desperately. But this is going to cause a major setback for Africa, which relies heavily on India for distribution of vaccines. When we look at the daily count of deaths per million people, we see here the curves, again, high in Uruguay and in Brazil. India is over here right now. Surprisingly, you see there's been an uptick in France. Don't really quite understand what's going on, although I suspect it's a similar situation to here in the US, where we have different clusters of people who think about the virus and the vaccine in different ways. And then we see the declines in death, notably in the US, and the UK has just done a really remarkable job of getting vaccine out. Turning to the United States, this is a 7-day % positivity rate from CDC, and the darker colors show a 6 to 10% rate, and the lighter blue is 0 to 5, and New Mexico has just no data. But we see, we see high rates in Puerto Rico and Michigan, the Midwest, and you may have heard a bit about the spikes that are happening in Oregon and now Washington State, which I think will probably pick up a bit more. We can also, drill this down now into hotspots across the country, and the only hotspot that shows up in New York State is in Lewis County, which I have to confess I didn't know much about. It's a small county, a small population, but you can see that these hotspots are scattered across the country, just to give you a sense of how this is being looked at. So turning to New York State, our 7-day average positive rate is now under 2,000. 2 days ago, it was just a little over 2,000. And our average rate is 1.2%. We've vaccinated 9.5 million people, which is nearly half the percentage of our statewide population. If I'm not mistaken, when I looked at the New York City rate last week, it was about 60%. There are 1,688 people currently hospitalized, with yesterday's deaths totaling 23. I talked to a colleague of mine who's in the Columbia system, and he said across 5 hospitals, they have 250 people hospitalized. And I've been asking a little more information. He said there are still some older folks that have comorbidities like diabetes and hypertension that are coming into the hospital unvaccinated, and then a lot of younger people as well. But he said what's notable is that people aren't staying as long. The people are either not quite as sick, or they're being managed a little differently, and they're not staying in the hospital quite as long. So our daily positive rate in New York has declined significantly, as have our hospitalizations, as I mentioned, and sort of buttress what we've heard from the Columbia anecdote. I thought I'd show you, you probably know this and read the local papers, but just in your own neck of the woods in Broome County, you've have had 18,000 and some people tested positive over time, and show up in this second highest tier. And the daily new cases per 100,000 is 14.6, with an infection rate of less than 1%. I don't want to talk about positive test rate because it's not necessarily unduplicated. 62% of your ICU capacity is used, and it looks like nearly half of the folks in the county have been vaccinated. So turning a little bit to clinical points, I think the take-home message is that the minute you might think you have COVID, you want to get in touch with your primary care provider as soon as possible. I think we've learned that the onset of loss of smell and taste is almost what we say pathognomonic or uniquely characteristic of COVID infection. And that should be the first sign when you talk to people that know they may have COVID. Some people get a very intense flu-like syndrome with fever for several days, profound muscle aches that may last 2 to 3 weeks. And of course, we know about the people who progress to pneumonia and can develop a very severe pneumonia requiring ventilation on a respirator. There are a lot of different neurological symptoms that people have, ranging from central neurological symptoms to peripheral muscle symptoms. We know there are a lot of clotting disorders, and the people that develop that bleeding in their lungs when they have pneumonia, and other types of blood clotting disorders that have been reported, and people are working furiously to really understand the mechanisms behind this. They're not, clearly really not fully worked out at this point. And then finally, I just wanted to mention long COVID, which is the term being given to people that seem to have a very long course of clinical symptoms. And this is manifested particularly in people who have that loss of smell and then wind up with taste coming back slowly, but with really abnormal taste sensations for a while, very significant neurological problems, lack of an ability to think clearly, nightmares, and psychiatric symptoms. And these may last for quite some time. And there's a lot of active research being conducted to understand more about this as well. What we've learned about therapeutics at this point is that, when you have the onset of symptoms, and particularly before real pneumonia sets in, if you can get an immune cocktail infused, and there are several different ones on the market. There's one from Regeneron, which is a New York State company, one from Lilly. They seem to really work quickly at preventing the onset of full-blown infection. And physicians are able to access this by prescription. So that's really made a major change in the rate of severe illness and death in management. For people who develop pneumonia, at the very beginning of the pneumonia infection, if they get steroids, they've been shown to be effective in what was a very well-conducted study with unusual findings. They found that if you waited too long, the steroids had no benefit. So they need to be given at a very specific window and early on. The antiviral agent remdesivir seems to be effective, some studies suggesting more or less effective. And then we have learned that if people do have to go on a respirator, they seem to do better if they are turned over regularly, and there are hospitals that develop teams of people that do this on a regular basis. So there are things that we've just learned over time about how to manage people who do get infected or develop pneumonia, severe pneumonia with COVID. Again, the main message is to let people know, or if you're talking to people, just call your provider early. We know that most people are asymptomatic with COVID, which makes this, particularly worrisome for transmission, because you just aren't going to know if somebody is liable to pass COVID on to you. And it looks like at least 60%. This slide is from earlier this year. It's actually from a talk that Tony Fauci gave at one of our HIV conference this year was half COVID and half HIV, since so many of the researchers have migrated into the COVID field who are doing virologic and immunological research. But 60% of infections result from people who are asymptomatic. This is what the virus looks like in large, electron microscopic photographs, and you can see these colored spikes coming off the virus. That's the spike protein that you may hear about in the news and is the target of antibodies and is the one that causes the infection to happen. And as I will talk more about the vaccine shortly, but just to say that we're very lucky that the Pfizer and Moderna vaccines are powerfully effective against COVID-19, and this has been confirmed in study after study. And as the J&J and AstraZeneca are also effective, as are the Chinese and Russian vaccines, but these two in particular, the mRNA vaccines, are really powerfully effective. So if you don't mind, I wanted to just talk a little bit about immunology, not to go over this whole slide, but to point out that, you know, there are two different arms in the immune system. And the first is our innate immunity, that is the line of defense against invading, you know, infectious agents or pathogens. And we have a whole host of cells and barriers to accomplish that. And then we produce antibodies through our B lymphocyte cells, and we produce a robust number of other chemical mediators and functions through our T lymphocyte cells that generate long-lasting immunity. The antibodies that we measure in the blood in the vaccine will go away over time. We don't see them necessarily circulating in the bloodstream, but the research right now that's been conducted to date suggests that this part of the immune system is very robust against coronavirus infection and lasts. And so, you know, for people that have been studied at the time that I've heard the research up to 9 months post-infection, they seem to have a continuing memory of the infection and are able to mount an antibody response against it. So it's that, I would say, is the most encouraging.
Oh, I have it, yes.
Positive news.
Well, you know, I don't know why I have to go through all of that.
And so the goal of our vaccines are, you know, to prevent infection by producing the antibodies and to reduce the severity of infection, which is again through those T cells. And so just as a short way of thinking about what we hear, and we tend not to hear about the long-lasting immunity from the news and the media. So just a little bit of good news about that. So let's turn to vaccination. And I think it's interesting to look globally at what the rates of vaccination have been. I think we've heard in the news a lot about what Israel did early on by purchasing a lot of Pfizer vaccine and rolling it out. There's been a bit of a plateau at about, you know, here 50, 60% with people, you know, fewer people not getting vaccinated. And you see how rapidly the UK ramped up vaccination, which has resulted in their declining rate of infection and mortality. You know, we're not too far behind here in the United States. I think, you know, and then we're going to see an uptick, of course, now with the vaccine being approved and for children and, you know, young adults. And so we'll see an uptick in vaccinations. And then I think you can see down here at the bottom, these low rates in countries like Turkey and Brazil that have large populations, in India, which is suffering, and in Asia and in countries that are, you know, have fairly advanced healthcare systems, then have not been able to access vaccine and distribute it. And of course, South Africa, which had a significant problem, is just slowly ramping up. We're going to see some improvement there. I have a colleague who just flew over there to spend a month there to do some work, and our South African colleagues are now all in the process of getting vaccinated. So I'm hoping that things will ramp up there. Looking at the same information in a somewhat different way, you know, we can see the disparities related to income and the continents, where, you know, clearly the rates in North America and high-income countries are much higher than in South America and in lower middle-income countries, Asia and Africa. And so this really points out to the disparities of access to vaccine. I think you may have heard that here in this country, we've just supported compulsory licensing of the COVID vaccines. which is the waiver of the intellectual property rights for public health emergencies. The World Trade Organization is allowing this under the TRIPS regulations. I know the IP is intellectual property, and I don't remember the rest of the letters at the moment. And that countries who apply for the waiver can manufacture their own vaccines or biologics without violating this international agreement. And this is how some countries, notably Brazil and some African countries and Thailand, were able to make their own generic HIV antiretroviral therapeutics. So this will be a major development going forward in ramping up vaccine supply. We have a lot of AstraZeneca vaccines sitting around, and it has not received emergency approval from the FDA. Seems to be very delayed. So we've already provided 4 million doses to our neighboring countries, and we'll be providing more to India, and one can only presume to other countries as well in the near future. China's been providing vaccines to many countries already. So let's talk a little bit about variants. There's a lot of media attention to variants, and viruses, mutate because they make a lot of mistakes. This virus doesn't have a lot of genes, and so when it keeps replicating, it makes mistakes, and then it turns out that some of those mistakes result in viral strains that enable the virus to be more effective in infecting and perpetuating itself, because it wants to keep surviving as much as possible. So the term variant of concern has been developed to talk about a viral strain which may show an evidence of increased transmissibility, more severe disease, a significant reduction in immune response, or reduced effectiveness or treatment from treatment or vaccines or diagnostic detection. The good news is that the mRNA vaccines seem to be quite effective. The other vaccines may not show up as effective in the antibody response, but they're also quite effective in preventing severe illness and death if you do get infected with the other strains. So we just have really good news about these vaccines. I think it's been a true, remarkable scientific advance that we got vaccines so quickly that were so effective. And so again, this is also from Dr. Fauci. We've learned over the past year that, in this country, we were not prepared to confront the global pandemic. The erosion of our public health infrastructure significantly impacted our ability to scale up testing, and we had a lot of mixed messaging. And I'll share some of my own thoughts about this. But I would also add right here that one of the other problems is a structural division of the public health system from the health service delivery system, which I think is a root cause of so many of the problems we have in our health system. So I want to share some of my own takeaway messages on different topics related to COVID, and let me start with transmission. In spite of what was said at the beginning of the pandemic, this is an airborne virus, and I think that that there was a reluctance to admit politically that this was an airborne virus and it harmed us tremendously. But we know that it's an airborne virus, and it's important to keep that in mind as we think about prevention. And that's why masks, when properly worn with effective social distancing, are highly effective to prevent transmission in most circumstances. But it also means that we need to think about ventilation. And so adequate ventilation with a sufficient number of air exchanges are critical to prevent indoor transmission. And they're still not being emphasized sufficiently. And John shot me an email that this is something that you're taking into consideration as you move into more in-person gatherings. I was happy to hear that. This has been one of the things that's just driven me a little nuts over time. Having talked to people that do occupational health, and they're called not sanitation engineers, blocking but people that work on this, they can tell you right up front about air exchanges and what works for getting rid of particles. We know a lot from tuberculosis and other types of outbreaks, and they weren't being listened to in the beginning. And it's been an issue with the schools, the buildings that don't have adequate air exchanges, were I think one of the factors that were not being given adequate attention in the beginning. Like all other viruses and infectious particles, the amount of virus that you get exposed to and its ability to actually get inside your body are also important factors for transmission. And so that again takes us back to distancing and masking. The scientific community and the media have latched onto this term about more transmissible variants. I don't like that term. I think it's very misleading. The reason that they say that is that there are more people getting the strains once they are around. But it doesn't mean that if you've got one of these variants coming at you and one that's not infectious, that the variant is more likely to get into you than the other virus. What we know is that if they do get in, they have a very much stronger affinity to the virus receptors. And so they will attach more quickly and more firmly. So you're more likely to get sick from the virus if you get exposed to it. And as a result, there are more infections and it's considered more transmissible and it survives longer. And so there's a selection for those strains. I think another concern and question that gets asked a lot is, well, if I'm vaccinated, can I get infected again? People with normal immune systems can get reinfected, but it is extremely rare. There are reported cases, there's no question about it, but the chances are just really, really, really low. And so these are, you're really quite safe, if you have been vaccinated. The mRNA vaccines, the Pfizer and Moderna, are being modified as we speak to include specific protection against the new variants. I think the Johnson & Johnson vaccine is an effective single-dose vaccine. There was a lot of attention to the very serious side effects that were caused, the clotting disorders, but they're also rare. And so therefore the vaccine is still being used and is an effective strategy. As I mentioned before, all of the vaccines appear to be highly effective in preventing serious illness and death if you get infected. And immunity appears to be present over time, as I have also mentioned. And so for some of us, it's really hard to understand why people don't want to be vaccinated. And, I respect people's right to have that opinion, but it's hard for me to really grapple with that because it's such an effective vaccine and there's so much both personal and societal protection to be gained from these vaccines. So I think we know that equity has been a huge issue that we've had to deal with because of COVID. And we know that our health system is not an equitable one, that people of color and people who are poor tend to not have access to health benefits. So this has been a focus of many plans for vaccine distribution. And I just wanted to pose some questions to think about. I think that I'm very committed to dealing with issues of equity, but I also think we need to think about, do we make equity the top priority over clinical vulnerability for prioritization of distribution of vaccine? How do we deal with these factors together as we move forward? I think is really the question, so that people who are the most likely to die if they get infected, are not somehow bumped in some way. And similarly, that we redouble our efforts to make sure that people who are underserved in our community are also not deprioritized in any way? And can we really reach those who are most disenfranchised in our current health system? I think that the people who initially rolled out vaccine by setting out mass distribution sites didn't really think about how people in communities, I think particularly of New York City, which I know well, but people who live in the Bronx and get their care from community health centers or private physicians were not likely to go to some of these mass vaccine sites or couldn't get to them. And that people who were elderly and living in extended family apartments couldn't get out of those apartments. And so they weren't being reached by the system either. And it wasn't until later that vaccines were distributed to the federally qualified health centers, the community health centers. And we haven't really tapped community health workers to go into homes or, visiting nurse services, for example, which would have been another way to reach people who were not necessarily accessing the mass distribution sites. And similarly, we didn't give vaccines to private physicians who are often trusted providers in any community. And I just happened to bump into my physician last week, and he serves a very diverse population. And he said he had people say to him, I'm not going to get the vaccine until you give it to me. And I think this is something that we need to think about in these situations, and especially if we are going to wind up needing boosters. I think when we think about vaccinating frontline workers, we need to think about, well, who are those frontline workers? We sort of understand typically in these situations that healthcare workers get protected because they have to be around to deal with everybody else. And then how do we define frontline workers? Are they transportation workers? Are they grocery store workers? And how do we do that effectively? And I think there wasn't really a systematic way to do that. And then lastly, we've seen the disparities in distribution of vaccine globally, and this is obviously a significant issue. And the only question I pose here is that in our thinking about this, as we look at the global community, is that, are we really thinking about what happens when we distribute the vaccine to another country and are vaccines distributed equitably in that country? And I have to say, in most countries, that's not the case, and we don't really think about that. And when you look at countries in Africa and that people where I work, and I talk to my colleagues and who I interact with all the time virtually now, the people who get vaccinated there are the people in political power, the wealthy people, and the healthcare workers. And there isn't like a coordinated approach to get the vaccine widely distributed out into communities. So something to think about. So, heading toward the end here, I've got a couple more slides. Learning from mistakes, I think, is in the slide from Dr. Fauci. There are quite a few. I'm drawing on that and a few other things. I put again up here because one of the things I did at the beginning of the epidemic was dive into books about the 1918 flu epidemic. And it was just striking to me that the situations were, you could have lifted them out. And they were the same political discussions. There'd be a wave of the flu, people were dropping dead, and the city council would meet, they'd have masking requirements. People would argue against masking and mandatory masking, and then they would relax the restrictions, and then there'd be another wave of infection. And it was literally the same discussions that were being held right around the same time that I was reading in the spring of last year. And from what I understand from a friend of mine who's read a bit about the yellow fever epidemics in the 19th century here, this is again a repetition. So we haven't really learned from our past experiences. And in spite of that, there is what they call a communication playbook for dealing with epidemics, where one of the central features is that the messaging is done by public health officials to relay accurate information. And of course, that was violated right from the beginning of the pandemic in this country, where the process became politicized and decision-making became politicized. And if any of you have read the great influenza book by John Barry, which is a highly readable book about that, he says, when you mix politics and public health, you get politics. And I think that's sadly what we saw. We made this mistake, as I mentioned, about transmission and ventilation, and people didn't want to admit that this was a danger, a clear and present danger, and so they downplayed the airborne transmission. And I've even heard this from public health people, one of whom is interviewed all the time on public radio, and she's often, just didn't want to admit that this was the case. And so I think there was a lot of misinformation, and I think I've already talked a little bit about vaccine dissemination. We've made some big mistakes, and no matter what community you were from, if you were 40 years old and had severe diabetes and were at high risk from illness, you weren't in the priority list to get vaccinated. And to me, this was, as a clinician, it was just a horrible mistake. If you can prevent death in any way, that's really where you want to start. And then within that, weave in your sociological issues and think about the who and the how in ways that we really tap into people's understanding and beliefs and attitudes about acceptance of vaccine and the health messaging, which is going to be different in different communities and has to be addressed from the very beginning of the process. And so as I wanted to finish up with this, since this has been, I think, something that has sparked surprise and questions, the new mask guidance about being able to go maskless, not just outside, but inside among vaccinated people. And I think that, the guidance here really reflects the science about the vaccine. I mean, the vaccines are so effective that we know that they can prevent transmission. And so it really then translates into messaging. So we've got policies related to this that we have to think about. Should there be a mask mandate or a vaccine mandate? And as we know, the word mandate just prompts, vehement response by people who just say that it's not the job of the government to mandate that we wear masks. There are certainly a lot of precedents where there are mandates for public health, and that's something we're going to have to deal with. The vaccine mandate, like in New York City, there is going to be a mandate for kids to get vaccinated before they enter schools, but there's not a mandate for teachers. The teachers union didn't want that, and so there's what really makes sense here, and what should we be doing? So our policy is going to put a lot of emphasis on the workplace. So workplaces are going to have to say, okay, what do we require vaccination of our employees? Do we trust them? I think Walmart just issued a statement that they are going to accept word of honor on people saying they've been vaccinated. We'll see how that plays out. Will there be outbreaks and from employees that will will have an impact? What are going to be the liability issues for employers that drive their policies on requiring vaccination? I mean, legally, they can require vaccination of their employees. And then finally, will there be workplace standards that get issued about this? And what, OSHA will have to develop some kind of standard. OSHA's normally slower at developing standards than CDC and, other health agencies. And so we'll see what happens. They do tend to be conservative usually, but we'll see what happens with that. Should there be incentives? There are a lot of companies and public policies, whether it's a Metro card in the subway. I took a train up here from Grand Central, and there's a walk-in line where anybody coming into the station can get a free round trip Metro North ticket if they get vaccinated at Grand Central. There's the hamburger and French fries. People are giving out cash in certain businesses. And there's a lot of questions. Well, what's this going to mean down the road if we need boosters? And does that mean everybody's going to have to get an incentive? And will people take the vaccine without an incentive? And then finally, the thing that I think is really what we should be doing is having some sort of a universal certificate system or passport has other implications, but when I travel, I have a yellow vaccine card. I can't get into certain countries if I don't have proof of yellow fever vaccination. I know other people in the past that have had to show proof of hepatitis vaccination. So that kind of an approach to me seems very appealing, that we all get certificates that say we've been vaccinated, and then the entry policies get determined based on either the employer or the immigration policy or whatever. But there's a lot of food for thought, and I'm happy to discuss that with you a little bit, and also, of course, answer any questions. But that's where I stop here, sort of a lot of interesting policy questions and issues. And anyway, so yeah, that's it for what I formally have to present.
Well, thank you so much, Bruce. That's terrific. Let's just open it up for questions. If you want to wave, if you could also use chat if you want to just write down a question. But let's start with waving. Right. Yeah, Glenn.
Yeah. Bruce, could you talk just for a minute as to why the public health system, is it, I guess, why we're not using more of the public health system? I think of visiting nurses, like you were saying, with people, those kind of things. Why isn't that being utilized more?
Yeah.
Do you have any insight to that?
I think this is, it's a symptom of the fact that the health delivery system is detached from the public health system. So there are some public health systems that have community health workers in them, but mostly these are, separate agencies, visiting nurse services, home health agencies. So they're not connected to the public health system directly. And, most states, New York is a little unusual in that, there's a long history of regulation and partnership with the healthcare delivery system, but not all states have that. The one example, the positive example that sticks out in my head is I heard on the radio, I think it was in Memphis, where they sent the county or city workers into people's homes where they knew there were people who couldn't get out to get vaccinated. Mm-hmm. And so there are examples of that, but our public health system operates on, it devolved to the lowest common denominator for the most part. So it's your county, your state, and when it gets down to implementation. But yeah, I think that's, in my mind, that's the one of the big gaps. And I don't think that then they gave the vaccines to hospitals in the beginning, right? And hospitals didn't all follow the guidance on prioritization. And the administrators all rushed to get vaccinated, and there were, lots of stories about that and so forth. So, it's a complicated issue. Yeah. Yeah.
And I still don't understand why they didn't give the vaccine to physicians. I just don't understand that.
I don't either. And I think, I just don't either. But yeah, I think that was one of the big mistakes.
Adrienne, did you have a question?
Oh, yes. Janine's diligently working with Beverly. Bruce, Beverly wants to participate, and she'll come with questions.
I'm sure she will.
Bruce and I and the others and John, we traveled China with was it 16 of us? Anyway, it was always interesting, All right, so I have two questions for you, Bruce.
Yeah.
Since you last saw me, I've reinvented myself. I'm a New York City school teacher.
Okay.
So I want to hear what your opinion is on the opening of the schools, because it's, you know, I teach middle school, so obviously with the 12-year-olds getting vaccinated, then the school will open. And then the other thing is Beverly is type O, so she's a universal donor. And I've read that that gives her special immunity. So unfortunately, she can't hear it from your lips, but Janine's here to back me up, whatever you're going to say about type O,
Okay.
special
Okay.
immunity.
Okay. Well, so first of all, the schools, right? So I that caught me a little bit by surprise at the beginning, but I think the bottom line that supports that decision is that the rates of transmission in schools have been like super low. And so people feel that schools are relatively safe places in terms of that. And now, especially with the vaccination, I think, as I mentioned, it doesn't make sense to me not to vaccinate teachers as well as students. But I think that, you know, you probably know there was sentiment in the union about not requiring teachers to be vaccinated. But it would seem to me that, I mean, everybody knows the benefits of having school open, right? And it's both for the kids, for the teachers, for the parents that don't have to supervise their kids during the day. You know, I think, so I just don't understand why there hasn't been more of a push to vaccinate teachers too. But the other issue was securing the safety of the ventilation in the schools. And, you know, the mayor, don't get me started on the mayor, but I think it took them a while to admit that they had ventilation issues. And, you know, then you'd have people that go on who had inspected the schools and broken windows, bad airflow exchanges. And then I've heard quietly that they've gone in to address these issues in a lot of schools, but I haven't really heard anything formal about that. So I think schools are probably safe to reopen, but I think they could do a little more to make them even safer as we go forward. So that's my opinion, you know. The blood type question is really interesting because it seems like the type A and AB and B are at higher risk of getting sick from COVID based on some epidemiologic studies, but we don't really know a lot about that. And there's nothing I can tell you that would say this happens because of X, Y, and Z. These are associations and epidemiologic studies that may or may not be proven scientifically, you know, causal down the road, but certainly something that people need to look at to understand more effectively as we go forward.
Nice. Yeah, I heard exactly what you said. It's the bloggers come out, you know, they read a line from a study and then they write a blog that looks informative. And so I guess I just read a couple of those and I was taking it to the bank. But yeah, Beverly still can't go to any restaurants yet. It's wonderful now. We can tell her what to do. Unless Trinity tells us, Janine and I don't live in Binghamton, so unless Trinity tells us, we don't know whether she does what we tell her or not, but you know, we enjoy telling her what to do.
So Wilma, I think you had a question?
Yes, I did. Because we have a little grandson, we're concerned about the age limit. It stops at 12. When they start giving to younger children, do they test them? Do they give them less? How is that all figured out?
So that's a good question. I can't answer you with 100% certainty because I haven't followed a lot of the details on this, but typically that's why when vaccines are released, they don't release them to all age groups, is because they need to study them separately to learn about effective dosing in children. And so, and safety, you know, and there's always concerns about the developing child and what the effects might be. And even when they do study, you can't really assess the long-term effects, right, in development. So there's always a question about that. But these vaccines appear to be, in general, very safe vaccines, and so I anticipate that they will lower the age limit soon. But you know, I have some, you know, colleagues that have kids that can't get vaccinated. And so like, it's this, you're kind of betwixt and between, right? Because you don't want to expose your kids to COVID.
Right.
And so they're a little handicapped with travel. Although, of course, if you're vaccinated, you can see your grandchildren and not, not worry about it. So.
Okay, thank you.
Yes, yeah. I see Diane has her hand up.
Yes, thank you. Bruce, thanks for a very informative presentation. I enjoyed it. Quick question. I got the J&J shot and I'm anticipating needing a booster, although that hasn't been specified for sure. But I'm wondering, can I get one of the messenger RNA boosters, or do I have to stick with the J&J? Thanks.
So that's a great question. And I think it's come up a lot. Should there be like some kind of a mix and match strategy with vaccines? It makes perfect sense, right? To try to tag the immune system in different ways. The problem here is that the process of issuing formal recommendations is, I would say, for better rather than for worse, a slow process, and that people don't want to make official recommendations until there have been ample studies conducted with data to say that this is the right thing to do or not to do. Another example of this is, well, people who've had COVID probably really only need to get 1 dose and not 2 doses because they have some immunity to begin with. But and any clinician or researcher will say that's probably what needs to happen, and that's been but yet the formal recommendation isn't there. To me, that makes an awful lot of sense. And that certainly if you are going to need a booster down the road, I would want to get a different vaccine if I could, in that situation, to strengthen the immune response that I have.
Thank you very much. I was thinking the same thing.
Yeah, yeah. John.
Yeah, I have a question about the intensive and repeated cleaning of surfaces that was so stressed a year ago before they understood things more. As you were saying, the understanding now is that this is primarily airborne. So what is your sense about the importance of carrying that on? That I really have not seen that addressed, and yet, it's certainly a something that every institution has to worry about, every store has to worry about.
Yeah. I prefaced my remarks by saying that no infectious disease clinician would ever say, don't wash your hands. Okay. I mean, so let me say that. I think it's really unnecessary to do all this cleaning. And I actually, the data were even clear early on that there wasn't transmission from surfaces and objects, but the recommendations have not changed. I don't quite understand it, but I think it's not necessary, and yeah, period. I think it's an opportunity to step back and say, look, from this attention to hygiene that we have undertaken, what makes sense to continue to do a better job than we did before, which was likely very little, and take it from there. It's like with masks, right? I mean, like when I go out walking in New York City in the park, I don't wear a mask, right? It's funny because my habit, as soon as I get to a crowd of people now, I put up my mask, and even though I don't really need to, it's just become a habit. Well, are we going to find ourselves being more like a lot of the Asian countries, and Japan in particular, Thailand, somewhere where people wear masks a lot? There's no question that it will reduce the amount of influenza and transmission of other respiratory viruses. So, so why not put on a mask when you go into a store or something like that, or you get into a subway? So, it'll be interesting to see how behaviors change over time, and whether we keep some mask wearing, which we know has other benefits as well, but we don't really need to wear one to prevent COVID transmission if we're vaccinated. And that was, like messaging here is like, I just slipped, right? But the headline on the local news station one day is, the guy was trying to be cute and clever, and he said, "And now you are free of masks." He didn't preface that by saying unvaccinated. And I think we're victims to all of this bad messaging. It's just unfortunate.
Any other questions?
Ooh, that's good stuff.
Yeah, Carlos, yeah.
I would just like to say that this has been a fantastic presentation, and I really, really am impressed with it, and thank you very much.
Well, thank you very much for that. Yeah, thank you.
Yeah, I would underline that. It's a terrific presentation, Bruce. Thank you so much.
Thanks. And I guess thanks for twisting my arm. I gave me a chance to reorganize my thoughts. So, and of course,
Right.
it's nice to see you and Adrian. And even though I don't see Beverly, you'll have to give her my best. So, yeah.